So you all can put your names and join the quiz. And there will be roughly 20 ECGs. And then so there will be about 20 questions, and during after each ECG we will be giving a short, actually he is the one who is the expert of ECG, so he will explain a little bit about, because I know you are already quite overwhelmed with the ECGs already. How can I stop this person talking?
Master Red.
Okay, no? Did all of you join? We have only 39 players, so I can see how many of you all are joining. There should be at least 60, no? Or a team the bag. Let's say again you can join as or a names also. Foolish boys are there. Foolish woman is there. Lady queen. 42 players. Okay, how many are there? 69? How many are there? Okay, 50 people are there, some have gone. That's right. 50 are gone? Yes. You all also can. Abhishek? Why join? You all should do. Play. If you all win, of course, we will just not give them. You all can play with the names of the originals. Okay, we'll start, no? 48. Please play, otherwise ECG is like, it's all based on the history. No, you can't interpret ECGs without a patient and a history. So therefore, when you are sent to cardiology ECGs, always send with the history. Otherwise, all these people who talk nice to you all, their true spirits will come out. Okay. And also you should be confident. You can make mistakes. Also, and everyone, you all make mistakes. Even EP person also make. Even these ECGs we showed, we also make mistakes. So therefore, don't worry about it. You can make mistakes, but you should make your mistakes confidently. Okay. You can't say and call this. There are some PVs You can't. You can come to a diagnosis and tell if it's wrong, they will definitely correct you. That's how you learn. Okay. If you are not confident, you will never learn. Okay. So the scoring system, for a correct answer, you get a score plus the faster you answer, more points. You are very expert in these pieces already, so he will be the quiz master. I was announced from. So he will be explaining. I will just do the technical part hopefully, and I can do that correctly. Alright, we'll start. So if this just runs off, I can't stop it in between, so try to get all correct. Good luck to everyone. No practice pieces here, just starting from the first question. I got first time using this form. Okay. Projecting, your screen might also have the ECG. Yeah? Okay. So KKK is leading.
So we asking us, basically we are going with the history.
Can you hear? Can you hear? This doesn't work.
We used to go with the history. So there are concave ST elevation, convex ST elevation. Conditions are always leukemia. Whereas if you see a notch-like thing, small notch somewhere here, it's usually seen in the inferior and the lateral leads. So if you see a notch-like thing, that is very suggestive. Early repolarization changes. So there's no obvious ST elevation in the ECG previously, and there's no reciprocal changes even. So these notch are based on these early repolarization changes. So this is benign early repolarization.
Forty-five seconds for question, 30 seconds. I gave more time. So basically.
You have no ECG. So if you don't find anything, it can be a normal. Even patient having a chest pain. We see a lot of patients having like this. As I told earlier, you look for ST elevation, reciprocal changes. Nothing is there, can be a normal.
And also some changes might be normal as well, right?
Yes,
Usually inversions V1, V2, those may be normal. If it's athlete, you might have LVH-like features. Those are still normal. That's athlete's heart. Things like that can also be normal. The athlete in the sense doesn't have to be a Olympic. External liver comes and you see LVH, maybe athlete's heart. Okay.
Hyperkalemia. History itself suggests patient edema and acidotic breathing. So if you take the ECG changes, usually you used to have tall tinted TVs, later on QRS longs and P patterns. The last ECG is hyperkalemia.
KKK is raising. Jay Sharon, somehow got it wrong.
changes of pericarditis, PR segment depression, and AVR you can see the PR segment slightly up, and the ST segment also usually is concave ST segment up you may see. So these are changes of pericarditis.
So with time also it evolves, like in a STEMI also, like initially you see this ST elevation, but subsequently with the time as it goes on with the stages, the T waves start to flatten and they can be T inverted as well, right? So pericarditis can also come T and there are stages in normal ST with time, okay? And ultimately in pericarditis ECG will be normal in stage 4. Let's see the leaderboard. KKK still leading. Okay.
First thing, your ECG, 25 years old patient, ECG sinus rhythm. So what you see, the RR intervals are kind of irregular. So what happens in sinus arrhythmia is when you have an expiration, you have a vagal tone. It decreases the heart rate. So you may see the bradycardia later on pick up heart rate. So during expiration, you may see the bradycardia. That is sinus arrhythmia. So it's a very kind of thing. If you remember sinus arrhythmia, that's enough. It's like tachycardia always algorithm works. So when you have tachycardia, look whether it's a sinus rhythm or not. If it is sinus rhythm, there is sinus tachycardia. Then look at the QRS complex. If it is broad, it goes to the ventricular origin CET. It's a narrow. Then look whether it's a regular or irregular. Irregular atrial fibrillation. Regular tachycardias are a kind of pre and primary. So basically in this particular ECG, you may see, if you see a lead 2, the P is like downside. So usually you see upright P in the lead 2. So co-ECG, the P is somewhere, it's going down and coming up. So P is coming from the ectopic origin. So you got an ectopic origin P with a tachycardia, that is atrial tachycardia.
Yeah, the P waves are inverted sort of things with a normal tachycardia, that's a atrial tachycardia. But if the wave is fibrillating like that's atrial fibrillation, so to like regularly, that might be atrial flutter. Okay.
we have to go with the history. That patient, 35 years old, patient coming in the shortest of breath, and you heard a murmur. So, you may see the large, deep cues are there. The target cues are some pathognomic of hypertrophic cardiomyopathy. That is hypertrophic cardiomyopathy. So, you may see some.
Yeah. So drug acutes is like it's like a sort of a pathological cue, but it's like a very narrow, complex cue wave that is seen in inferior leads. Okay. In top of that, the patient has LVH also, so that's more suggestive of left ventricular hypertrophy. Leaderboard, the still KKK has dropped like J Sharon has dropped down.
So, tachycardia algorithms, every side broad complex, narrow complex, broad are VPs, narrow complex are regular, SVG, so-called SVG, and irregular ATP. Go with algorithm, that's easy.
What is always the regular narrow complex tachycardia, which is SVT, which can be AVRT or AVNRT, which is none of your business. You don't have to worry about diagnosis. That only they are. Still, AKK probably, he has got it correct. Okay, J Sharam and KKK are fighting champions.
Ischemic ECG, when you interpreting the ischemic ECG, we look for territories, 2, 3 AVF, with this V1 to V4, with a 1 AVL, V5 to V6. This 2, 3 AVF, it's inferior, V1 to V4, anterior, 1 AVL, V5, V6, it's a lateral. So depending on basically which artery it supplies.
So this was ECG as a household, you should never miss. STEMIs you can't miss.
This is, you can see flutter waves. Flutter waves are usually visible in inferior and V1. So look at the 2, 3 AVF. You may see the sawtooth-like appearance. So at the V1 is the upright. So these are classic features of flutter wave. You see 2, 3 AVF and V1. what should be there to diagnose flutter? Sometimes it depends on the AV conduction, sometimes 3 T waves conduct to the AV node, sometimes 2. It depends on the AV conduction. So it is atrial flutter.
Again the same algorithm, it's a tachycardia, narrow complex, irregular. So it's AF or AF, atrial fibrillation. So here you see flutter wave, so it's atrial flutter. Okay? How the leaderboard is. So new people have come. Everyone has got it wrong.
So bradycardia algorithm, like first you see the sinus rhythm or not sinus rhythm. Either it's a first degree, second degree, third degree. First degree you have prolonged PR interval. Second degree, Mobis type 1, PR prolongs and drop QRS. Real problem comes when it's a type 2 AV block for complete heart block. If you see more P's than the QRS, say it's a complete heart block for type 2 heart block. To differentiate type 2 from the complete heart block, look at the PR interval. PR interval always constant in Mobis type 2 block. Complete heart P interval and P marching around the QRS complex.
Given the context of the history, this one came with the episode of suicide attempt. So yellow oleander and digitalis causing heart blocks is something that as house officers you will have to diagnose. If it's a young patient with a complete heart block, you have to put a TPM and save the life. So until the digitalis goes off from circulation, right? So as a house officer, you should be able to diagnose a complete heart block. Yes, SSR also. New leaderboard, completely different leaderboard.
So you can see the previous ECG, you can clearly identify the pacing rhythm. So anything if you pace from the right ventricle, anything coming from the right ventricle, it derives to left LBB morphology. You have pacing rhythm with LBB morphology. So that is basically pacemaker. If you see two spikes, that is dual chain. If you see a single chain, so previous ECG is single chain pacemaker.
And the key also the patient has non-cardiac chest pain, okay? So LBB care don't thrombolize those patients who are on pacemakers. You will probably kill the patient with ICH. You are easily confident in diagnosing these fast responses. Yeah, if someone got this wrong, we should actually cancel the MBBS. So let's see who has got it wrong in the next. We have done a relatively good job, colleagues. Only if you have got it wrong. Okay.
So this Torsades point is, you can see the pointed tips is turning around. You can see it is a blunted tip, it is pointed tip. If you trace the pointed tip, it's turning around. So it is Torsades point. Usually coming with hypomagnesemia, hypokalemia, which trigger this kind of pain.
So here apply the same thing. If you see, it's just a VT. If you diagnose it, that's enough. But for the which may make it more difficult, but you all can get it a VT, that's fine. So for those who got it wrong, if you got it VT, that's enough. Huh? Okay, Jayasharan has come back to me. Now he's going down. Commentators curse.
So three kind of ST depression. There is upsloping, downsloping and horizontal. The downsloping and horizontal ST dips are significant for ischemia, whereas upsloping is not suggestive for ischemia. It's always given by downsloping and horizontal, very suggestive of ischemia.
And also in this particular ECG, why non-STEMI came first, they have done a troponin. Troponin was positive. Troponin was negative, so have been non-STEMI. This is I think the most difficult ECG. Okay, you have got it correct.
LBB. I always say look at the extremes of lead. Look at middle and extreme of lead. Middle lead is V1. If you see notched S wave, and the extremes of lead, that is 1 and AVL. 1 and AVL, if you see notched R wave, that is very suggestive of LBB. The RBB other way around. You may see the RSR on V1 is in lead 1 and V. So this particular ECG, the quiz-ECG, you may see the irregular rhythm. No piece, irregular rhythm, that is atrial fibrillation.
You can have atrial fibrillation. But if you get this wrong, that's fine. If you just manage the LBB, that's okay. No? Yeah. You not kill the patient. Huh? Yeah. This has to be 100%. The echo misses this, patient will be in the mortuary. Let's see. Okay. Good, good. Lot of people have got it correct. AK is again coming back.
Algorithms. It's not sinus rhythm, look for QRS. Road QRS. Unless proven otherwise, why body heat? Remember this.
So it's a regular morphology compared to the Torsades pointis that was there before. So that this is a monomorphic sort of V. And from pharmacology, you know, tricyclic antidepressant overdose can cause ventricular tachycardia.
Balance when you have type A and type B. Type A you may have biphasic P, whereas type B you may have P inversion. So differentiate from the apical cardiomyopathy, the R wave is usually got in the apical cardiomyopathy. So type B Wellens.
Yeah. So it's Wellens diagnosis not on the ECG but on the clinical presentation. Where normal you get down and get the ECG and you see biphasic T inversions. It may be LAD occlusion in that random patient, but you won't manage as for a Wellens for that one. Okay. So it's always with the history manage the patients. Otherwise, it will be very difficult. And what is the importance of a Wellens is that it means a left main or a very proximal LAD occlusion, which is an indication for early angio, but not for thrombolysis. Okay. We are coming to the last few questions.
Look at the history. Patient chest infection comes with a dizziness. So you look for arrhythmias. So if you look at the EVs prolonged, there are three kinds of QT, long QT syndrome. You may have type 1, you have road-based T. And you may have type 2 and this kind of late peaking T. And type 3 pattern you may have biphasic T. These are the three types of long QTs. So patient respiratory tract infection might have macrolide, which was cardiac. We look at the leaderboard now, and now only 2 more questions. AKK is coming back, so he might make it. This is called electrical alternans because the heart moving here and there, moving around in the pericardial cavity, you may see QRS alternans pattern. So the QRS alternans usually seen in pericardial fusion.
Flu is it's a lung CA patient, so they can have pericardial fusion. Oh. I don't know. Okay.
So this is clear-cut STL, you should no doubt about that. You can see the P marching around the QRS. P here, P here, P here, P here. Should become here. So more P's than the QRS. PR indoor is very, sorry, this is complete outcome. So 2-3 AVF situation, inferior STEMI with the complete outcome.
Yeah. So inferior STEMI is associated with complete or any degree of heart blocks, plus RV infarctions, posterior infarctions, and things like that. You can see CEPG. So in a STEMI or whatever ischemic event, always you have to see beyond the STEMI, like whether there are arrhythmias or anything. Okay. So having said that, nothing all the questions, we are going to look at the winners and let's see who has won this quiz today. Okay, so we are taking back. Who are you? Who is Jahan? Who is Jahan? Congratulations. Who is the KKK who went up and down now? Jay Sharon. Congratulations. We also have Che. Che is good. Che. Dilmi. Okay. Congratulations everyone. Good job. This is a difficult question, difficult quiz we all talk, but we want to make it difficult so that you all get motivated to learn more about it. So I think, I don't know whether we succeeded in doing that, but we did what we wanted to do. Okay, thank you.
Dr. Leonard and Dr. Kalainesan for that exciting and catecholamine-inducing sort of quiz for today. Before we conclude, I'd like to ask the first 6 on the leaderboard. That includes number 6, Laz, whoever that was, isn't it?
I think I have read the results wrong, it seems. Now only the real results come. That was for the last question, I guess. I don't know whether clinical society manipulated because his computer disease.
So who are the first 6?
Yeah, I got the first 3.
Who left?
Who left? View leaderboard. And you can go down. Okay. So there's a little difference to that what I announced. They changed. I think that was the last question.
Quiz. So his name is missing completely.
Do you remember how much?
Yeah, I have photos.
Did you leave early?
His total mark was 14,025.
Ah, okay. So that's a good